Hawkins at Alpine Spine and Sports. For the video preceding this, we'll show basically what we call a CMC Joint Injection, which stands for carpal metacarpal injection. That has to do with the area here in the hand where the carpus or carpal bones meet the metacarpal, hence the name CMC. It's actually one of the site of primary arthritis in the hand, and probably the most common site of arthritis in the hand, which is not secondary to other factors such as rheumatoid arthritis, gout, and things of that nature. We have an x-ray here that we can show you. It gives you an idea about the anatomy of what we are seeing. Again, this is the metacarpal phalangeal joint. You can see here that there's significant destruction of the CMC joint. Basically, the trapezius here in this area, or the trapezium rather, has been denuded and ground down. You have areas of bony sclerosis with subchondral cysts, large osteophyte formations, and here, also dorsal displacement of the joint. I will note that even with this, while this becomes destroyed and you lose the ligamentous structures, or rather the integrity of the structures, this will also lead to secondary hypermobility of the MP joint, which in a surgical case or management of this should include stabilization of not only the CMC joint but the metacarpal phalangeal joint as well. Today, however, we're talking about conservative management, which includes injection, bracing, or splinting, and that's where this is going. But at any rate, this is what normal articular surfaces should look like, this being the scaphoid, the capitate, the second CMC joint here. You can see the lines there, and you can appreciate how those are nice and smooth, and then here you pretty much have loss of identification of that as well. Second to that, we can develop what's called STT arthritis, which develops here. In this individual, there doesn't seem to be much STT arthritis, pretty much isolated CMC arthritis. Well, how do you get CMC arthritis? Essentially, it's an overuse problem where people may have had an injury in the beginning or many years ago. They've damaged the cartilage, or they may have an instability problem that leads to destruction of the cartilage, and then you form arthritis. So the definition of arthritis is inflammation or destruction of the joint, which, as you can see on the photograph, that we had pretty much a complete loss of the articular surfaces. So I'm going to kind of talk to you through this, like
Okay.
it's the first time.
Okay.
I know you don't want to watch.
I'm not going to be looking, but I can still respond.
So remember, the first thing that we do is we try to identify where the joint is located. We do that by flexing and extending at the CMC joint. And we can feel the base of the metacarpal, and that's where she's tender. So I kind of put my fingernail there, and then we'll take the edge of the syringe and mark the area. And we can see that that's where that's at as we move that back and forth. So I like doing that because it leaves a nice little red target area for us to see or reference when we do the actual injection. I'll just have you rest your hand on my leg there. Perfect. One of the keys to this injection rather, is to have the patient relax as much as possible. And I'll apply distal traction, and again feel that where the joint is located. And as you can see, that's right into the joint. Make sure that we have not hit or gone through the dorsal branch of the radial artery. And go ahead and try and relax. Good. Doing all right? We're almost done. All done. So one of the tests we can do to make sure that this injection was successful is we place lidocaine or marcaine into the injection, and the patient should experience significant pain relief almost immediately. So I like to have them do a pinch test, so go ahead and pinch for me. Go ahead and squeeze real hard like you're going to pinch. How does that feel?
Good.
Lot
Yes,
better?
yes.
Okay, fantastic. All right.
Yeah, I feel immediate results always.
Perfect. Thank you for watching.